Hi, my name is Chris Bashi. I'm an emergency physician at Mercy Hospital in St. Louis. Today we're going to review obstetrical and gynecologic emergencies. Let's talk a little bit about normal pregnancy first. Uh, During normal pregnancy, the baby is within the uterus, floating in some amniotic fluid. The baby is connected to the mom through the umbilical cord and the placenta. The placenta is responsible for gas, nutrient, and waste exchange. It also provides a barrier against some toxic substances. There are other toxic substances that can cross the placenta, and that's why we know that those substances are dangerous during pregnancy. If you look at the umbilical cord in cross section, it has two arteries that carry deoxygenated blood and one vein that returns oxygenated blood to the child. It is a closed system. When you're cutting the umbilical cord, as we'll discuss later, it's good to leave a little bit of maybe 4 to 6 inches of space before you cut the cord. That allows us to place an umbilical vein catheter in the hospital, which we can use for venous access in the child if we need to after birth. And again, the amniotic fluid surrounds the baby and protects the baby in the amniotic sac, which is inside the uterus. Now, during a normal pregnancy, the uterus is going to go from the size of about a fist all the way up to a large 9-month uterus, as you see in that picture there. At about 4 months, the uterus reaches the umbilicus. Mom's going to go through some physiologic changes during the pregnancy. She's going to have increased cardiac output and up to a 20 beat per minute pulse increase late in the third trimester. During the second trimester, her blood pressure is also going to decrease about 15 millimeters of mercury. You may be called to the scene of a minor motor vehicle collision, and you may find a pregnant patient in her third trimester that is a little hypotensive and a little tachycardic, but that may just be normal for her during the pregnancy. If we have to transport that patient, we're going to want to place the patient on their left side. If you place the patient in the supine position, the uterus is going to rest on the inferior vena cava, and it's going to diminish the blood that's returning back to mom's heart and may affect her cardiac output. And that could certainly cause problems with the fetus. So we want to make sure we transport mom on their left side when they're in the third trimester. Now, trauma during pregnancy can be a big problem, although the baby is fairly well protected. Only about 1.6% of fetuses die when mom's injuries are non-life threatening. So even though we transport quite a few of these people for evaluation, they only miscarry or have fetal demise less than 2% of the time if mom has non-life threatening injuries. Now you see this rises to 40 to 41% of the fetuses die when mom sustains a life-threatening injury. So even still, the baby is fairly well protected even when mom has serious injury. The problem, though, comes if mom becomes hypotensive or hypoxic. The baby usually has problems if it gets poor perfusion from the mother. So we want to make sure we treat hypovolemia and hypoxia aggressively and that we control bleeding. If mom loses her vital signs as she's after about 22 weeks, we can do something called a perimortem C-section in the emergency department. That will involve doing an emergent vertical incision in the abdomen and basically delivering the child, which a lot of times would mean the child would be premature. But after that, the uterus and it will contract down, and mom will get basically a blood transfusion from the blood that's within the uterus, and so that may help her during a resuscitation. But again, this is if mom loses her vital signs. What they're showing there in the picture too is, if you can't put the patient on their left side, you can use your hands to manually displace the uterus off to the left, and that will assist you in keeping that uterus off the inferior vena cava. The good way to remember this is that the bench seat of the ambulance is on the left side. You always want the patient facing towards you and not away from you. So just a good thing to remember to place the patient on their left side if they are in the third trimester. Okay, now we're going to talk about something called preeclampsia and eclampsia. This is also something known as toxemia of pregnancy. You'll see this after 20 weeks gestation, but it can also occur up to 2 months after delivery. And what you see here is high blood pressure, which is usually a blood pressure of 140/90 or greater. That may not seem like very high, but when you think that most of these pregnant women are young and healthy females who actually in their second and third trimester should be a little hypotensive, that is significant hypertension. They also have edema as well as protein in their urine. Eclampsia occurs when they have seizures or coma. That's when preeclampsia becomes eclampsia. The treatment for this is basically to control blood pressure and control seizures. The definitive treatment is delivery, although as I said, this can occur up to 2 months after pregnancy. The symptoms of preeclampsia, unfortunately, a lot of these we also see during pregnancy, but headache, hyperreflexia, dizziness, visual problems, nausea and vomiting, right upper quadrant pain, as well as weight gain and edema. That's preeclampsia. A lot of times they will be diagnosed as being preeclamptic by their OB/GYN because they check for protein in the urine, they see the edema, and they note the high blood pressure. And again, preeclampsia becomes eclampsia when you have seizures or altered mental status. So if we encounter a seizure in a pregnant patient, what you want to do is place the patient on the left side, again, displacing the uterus off the inferior vena cava. Remember we said that if mom has hypoxia or hypovolemia, the child can have problems. So go ahead and place mom on oxygen. Go ahead and get IV access and place her on a monitor. Now the treatment for an eclamptic seizure is magnesium. Usually the dose is 4 to 6 grams IV, given over about 20 minutes for blood pressure and seizure control. This may cause respiratory depression. It will also cause a decrease in her deep tendon reflexes, and that's something you should monitor as you administer this drug. This is something we obviously don't do very often, so I would call for orders if you have to do this. The antidote for too much magnesium is calcium gluconate if you need to give an antidote. But again, this is something we're going to give over about 20 minutes. Now, Valium, Ativan, and Versed are all Class D medications. We know there's some harm during pregnancy to give those to mom, so they are not our first line drugs for seizure control. But again, we have to treat mom to save baby. So if mom is in status epilepticus despite magnesium, those may be drugs that we consider. But again, I would not do that without calling medical control first. All right, let's talk about some causes of vaginal bleeding. You see here the female anatomy. We have the ovary on either side, and then a fallopian tube on either side that connects down to the uterus. The uterus is separated from the vagina by the cervix, and that all these areas are important when we talk about the different causes of vaginal bleeding. Most of the time we see vaginal bleeding in the ER. It's usually just dysfunctional uterine bleeding. Those folks usually are not anemic. They're usually not hypotensive. They usually don't need resuscitation. But there are a few times we can see vaginal bleeding that we need to do some things, or they may be life-threatening or threatening to the pregnancy. And so we'll talk about some specific things that are difficult from dysfunctional uterine bleeding here. First one's miscarriage. Second one's ectopic pregnancy. Third one's abrupto placentae. We also have placenta previa, uterine rupture, and postpartum hemorrhage. And we'll talk about those all individually here. Let's talk about miscarriage first. This happens in 1 in 10 pregnancies, so it's actually fairly common. Usually happens in the first trimester, usually before 20 weeks. As distressing as this can be for the parents, usually they can be reassured by knowing there wasn't anything they could do to prevent the miscarriage. A lot of these miscarriages that happened early in the first trimester are simply because the sperm and the egg didn't come together properly. It was a pregnancy that was doomed from the start. There was nothing they could have done differently, and they just were going to have a miscarriage. But any tissue that you find should be saved for analysis. It doesn't happen often, but you can treat mom for hypovolemia. Now remember, we a lot of times will encounter a patient who's pregnant and having bleeding, which is very common. About a third of pregnancies will have some element of bleeding during the pregnancy and go on to have a normal delivery. But when that happens, we consider this a threatened miscarriage. So go ahead and treat them with some IV fluids and transport them to the hospital for evaluation. Okay, ectopic pregnancy. What happens here is that the fertilized ovum implants outside of the uterus. Fertilization usually occurs in the fallopian tube, and then that embryo then goes to the uterus and implants. But if that happens inside the tube, as you see there on the left side of the picture, the pregnancy will get larger and larger, and eventually it may rupture the fallopian tube and the blood vessels that run in that fallopian tube, causing hemorrhage. This happens in about 1 in 200 pregnancies. It can be life-threatening to the mother. About 11% of all maternal deaths in the United States are due to hemorrhage. Risk factors for this would be anything that would scar your tubes, like pelvic inflammatory disease or previous sexually transmitted disease. If they've had a previous tubal pregnancy, if they've had a tubal ligation, or they have an IUD in place. Some people may not even know that they're pregnant when this occurs. If you've had your tubes tied and you still have your ovaries, there is a chance you could get pregnant. And if you get pregnant, there's a chance you could have an ectopic pregnancy. This may present as vaginal bleeding or just abdominal pain. They may have signs of shock. If the tube actually ruptures, you're going to have somebody who may be hypotensive and tachycardic with a sudden onset of severe left or right lower quadrant abdominal pain or pelvic pain. Sometimes these folks will look like a kidney stone. but they will have much more tenderness in the abdomen than you would expect from a stone. They need to be treated aggressively for shock, so go ahead and give them IV fluids and resuscitate them and transport them emergently to the hospital. This is a placental abruption. What happens here is you have a detachment of the placenta from the uterus. This may cause some bleeding if that abruption tracks all the way down toward the cervix, but the bleeding can also be concealed if the placenta does not detach completely. This can happen after about 20 weeks. It happens in about 2% of pregnancies. Risk factors for this would be high blood pressure, preeclampsia, trauma, or people that use stimulant drugs like cocaine or methamphetamine. The presentation here will be abdominal pain, maybe some mild vaginal bleeding and shock in the third trimester. And again, the bleeding can be concealed. So you should treat these folks for shock with fluid resuscitation and transport them to the hospital. This is placenta previa. What happens here is the placenta implants low over the uterus. This happens in about 1 in 300 pregnancies. Usually we see this on ultrasound. And what you get here is some mild, painless third trimester bleeding. There's not much you would do about this in the field. This is uterine rupture. What happens here is the uterus actually ruptures and spills the the contents into the abdominal cavity. Basically, this can happen spontaneously or be due to trauma. If it happens spontaneously, it's usually someone that has a previous uterine scar, usually from a previous cesarean section. This happens in about 1 in 1,400 deliveries. This is a significantly high fetal mortality rate and actually a 5 to 15% maternal mortality rate. This is usually a pretty big deal. You have a sudden tearing abdominal pain as well as shock and maybe some vaginal bleeding in the third trimester. Again, transport these patients emergently and treat them for shock. Okay, let's talk a little bit about the stages of labor. There are 3 stages. The first is the dilation stage. Here you're having contractions and cervical dilation. Happens in about 12 and a half hours if it's your first child. And then if you've had multiple children, it takes about 7 hours. What's going to happen is the cervix is going to dilate to about 10 centimeters. On the right, you see kind of a visual aid there. 10 centimeters is roughly the size of a roll of cheap toilet paper. And then there's a gauge for how to measure how dilated the cervix is if you check the patient. Everything from a penny to an Oreo to a soda can to a donut, again to a roll of toilet paper. So again, you're going to see dilation from about 2 to 10 centimeters. Next comes the expulsion stage. Here you have full dilation of the cervix, and mom is going to be pushing the child out, and this stage lasts until the child is delivered. This is followed by the placental stage, and here we have just delivery of the placenta after delivery of the child. All right, anytime you get called for a pregnant patient who may be in labor, you need to make a determination as to whether or not you're going to do an imminent delivery in the house or if you've got time to take that patient to the hospital. And once we get to the hospital, we need to know if we're going to deliver that patient in the emergency department or if we got time to take that patient up to labor and delivery. So signs of an imminent delivery would be anybody who's having contractions which last about 45 seconds in length at about 1 to 2 minute intervals. If mom's telling you she has the urge to push, or if you look down there and you see crowning. You got to take a look at the patient. I know sometimes it's awkward in the field, but if you take a look and you see the baby's head down there, which is what we call crowning, as you see in the picture there, that's a sign that delivery is imminent and we need to set up to deliver the child. If you're going to deliver the child in the field, all right, what you need to do is position the mom. Women have been delivering babies without our assistance forever, and basically our job is basically to coach her through the delivery, prevent an explosive delivery, and to take care of the baby once the child is delivered. So in most cases, we're just assisting a natural process. We're going to help prevent an uncontrolled delivery, and we're going to protect the newborn from cold and stress. If you decide to deliver the child in the field, what you're going to do, usually the babies rather come out head first. You're going to place your hand, as you see in the top picture, on the perineum to basically prevent an explosive delivery and any tearing to the mother during the delivery of the child. Remember, don't pull on the head. Mom's going to push the baby out. We're not pulling the child out. You're going to look, once you deliver the head, for what we call a nuchal cord, or a cord wrapped around the baby's neck. And at that time, you're going to try and reduce that before the rest of the child is delivered. You're also going to try and suction the nose and the mouth, which is best done before the child takes its first breath to prevent it from aspirating. Once the head is delivered, the child's going to make a rotation and place the shoulders in the anterior and posterior lie like you see there in the bottom photo. Again, most infants are going to come down face down and then make this rotation on their own. Basically, what we're going to do at that point is gently guide the head down to deliver the anterior shoulders and then up to deliver the posterior shoulders. After that, you're going to deliver the rest of the child. But once the shoulders come out, everything else is going to come out very quickly. Remember, babies are very slippery. You're going to want to make sure you catch the kid in a towel or something to prevent you from dropping the child or a blanket. And once you've got the baby out, you're going to begin drying the baby off and keeping the baby warm. You want to make sure you hold the baby at the level of the vagina while you're clamping the cord. You don't want to pick the child up. Go ahead and put the clamps on like you see in the photo there, about 4 to 6 inches from the baby, and then cut in between them. Okay, after the child is delivered, we have to evaluate the infant. You want to make sure the infant is dried and covered. Babies come out all wet and they need to be dried off so they don't get hypothermic. You're going to suction the baby and stimulate as you need to. And then you're going to assess APGAR scores at about 1 and 5 minutes after delivery. Now, I don't expect you to memorize the APGAR score, but most of us are using electronic medical software, which will probably prompt us for an APGAR score and should give us the information we need to provide a score. This is the APGAR scale. The lowest score is 0, the highest score is 10. You don't have to memorize it, like I said, but you should be thinking about what we're trying to gauge as we're resuscitating the child. So the first thing we look at is the appearance of the child. Is the child blue all over? Does he have just blue hands and feet, but centrally he's pink? Or is he pink all over? Look at the pulse of the child. Is the pulse absent? Is it less than 100 beats per minute, or is it greater than 100 beats per minute? What about the grimace? Is it absent? Does the child grimace, or does the child cough and sneeze as we stimulate it and suction the child? What about activity? Is the child limp? Does it flex its arms and legs, or is it just very active? And then also look at the respirations. Are they absent? Are they slow with a weak cry, or good with a strong cry? So again, you're going to assess this score at 1 and 5 minutes. After the delivery of the baby, we have to deliver the placenta. This takes some time. Usually it takes about 20 minutes or so. Don't pull on the cord. Don't rush this. We don't want to tear the cord and we don't want to tear the placenta. Once the placenta comes out, we want to make sure that we examine it, make sure it came out intact so that there's no pieces of the placenta left in mom. You can see excessive bleeding at this stage. This can be controlled by massaging the mom's uterus through the abdomen. If the baby's doing well, you can also let mom breastfeed. That will also stimulate some contractions and slow bleeding down. But do not place any vaginal packing. That's not going to work to slow down the bleeding. Okay, and so now we're going to look at a movie of how this looks. Here we see the dilation stage. You notice the baby's moving down toward the birth canal. In a second here, they'll show you the cervix dilating and effacing to let the baby pass from the uterus into the birth canal. And here's that cervical dilation, dilating to about 10 centimeters, and you see it effaces, it kind of disappears there. And this allows the baby to proceed into the birth canal. And so now baby's going to drop into the birth canal, and we'll see the delivery stage. And so here we're seeing the baby crowning as we described there. You should be able to see the baby's head at this point. You see the baby's going to come out face down. And once the head is delivered here, you'll notice the baby's going to make a turn. And those shoulders are going to be in the anterior and posterior lie. You're going to bring the baby down and deliver the anterior shoulder first, then the posterior shoulder, and then everything else just comes out right afterwards. This is what the delivery looks like in real time. Again, I apologize for the quality of this video. I got it off of YouTube. But you see here the baby's crowning. We're going to have delivery of the head. And then we're going to see the delivery of the anterior shoulder. So they're going to bring the baby's head down. Here comes the anterior shoulder. And then the posterior shoulder. And then everything else comes right afterwards. Another view of that here. We see with this video, you see that hand on the perineum there preventing an explosive delivery. The baby's head comes out first. Here comes the anterior shoulder and then the posterior shoulder. And she's making sure the cord's not around the baby's neck and then delivers the child. Okay? So that's what's supposed to happen. If it does not happen that way, you might see something called a breech presentation. This happens in about 4% of term deliveries. And what happens here is the presenting part is not the head. If this occurs, there's not much you can do about it in the field other than to try to allow delivery to proceed normally up until the umbilicus. After that, we're going to try and gently rotate the fetus to align the shoulders in an anterior-posterior fashion. Obviously, got to be very careful with the child's head and neck. And then what we're going to do is try and deliver the posterior shoulder first, and then bring the baby down and deliver the anterior shoulder. So basically, everything here happens in reverse, but we want to be very careful not to pull the child out and avoid excessive neck traction. This is another problem that can occur during delivery. It's something called shoulder dystocia. What happens here is that basically the shoulders get stuck on the symphysis pubis, and this can be a real problem even in the hospital. What will happen here is you'll deliver the head, and then you'll notice that the baby's not coming out after that. What you see in the bottom photo is something called the turtle sign, where the baby's head retracts back into the vagina after delivery, and it becomes very difficult to get the child out. This is a very serious problem because the child can be susceptible to birth injury, like a brachial plexus injury, anoxia, or even a clavicle fracture. Ways we deal with this is something called McRoberts maneuver. You see that in the upper picture there, where basically you take mom's leg and you elevate the legs above her head. Hopefully what you're doing there is changing the angle of her pelvis, allowing that anterior shoulder to deliver. The other thing you can try is some suprapubic pressure, trying to push that shoulder down below the pubic bone. I have the Brown and Crouppen logo on here because this is a very high litigation delivery because a lot of times there is birth trauma to the patient, and so there can be problems here with hypoxic brain injury or, like I said, brachial plexus injuries involving nerve damage to the arm, preventing it from working in the future. So we want to make sure if this happens, we document that we tried McRoberts maneuver and then we tried some suprapubic pressure trying to get the child out. This is just a demonstration of McRoberts maneuver. And so you see here we're elevating the legs up above mom's head, and then they'll show you a cross section here as to how that changes the angle of her pelvis. And so here you see that that pelvic angle is changing, allowing that shoulder to get below the symphysis pubis and the child to be delivered. Now, we can also see a prolapsed umbilical cord. What happens here is the presenting part is the umbilical cord itself. As awkward as this is, you got to take a look down there when mom calls you for a potential delivery. And if you see that cord coming out, you need to insert 2 gloved fingers and basically keep pressure off of the umbilical cord. If that umbilical cord kinks off, that's the baby's blood supply, and this child can be born with some hypoxic brain injury. And so we want to make sure that we document we transported the patient with 2 fingers on either side, 1 finger on either side of that cord to keep pressure off of it. All right, after the child is born, we need to resuscitate the child. You'll notice in the photo there, they've placed a hat on the baby's head. The reason we do that is because the baby's head is a much greater proportion of its surface area compared to the rest of the body than it is in adults, so they lose a lot of heat through their head. So we go ahead and warm the baby up. We also want to start drying the baby off, stimulating the baby, and suctioning the baby. If we need to, we can apply some oxygen or even use an ambu bag, or in rare cases, intubate the patient if need be. We'll also focus on CPR if the patient's pulse is less than 60, and give medications if we are resuscitating the child. I'll show you a little bit about what the newborn algorithm looks like here. So again, we're going to provide warmth, we're going to position and clear the airway, we're going to dry the baby off, we're going to stimulate and reposition as we need to. Then we're going to evaluate the respirations. If they're great, respirations are fine and their heart rate's greater than 100, but they're cyanotic, we're going to go ahead and give supplemental oxygen. If that cyanosis persists or they're not breathing properly, we're going to go ahead and bag the patient with positive pressure. If their heart rate is less than 60, we're going to go ahead and start chest compressions. And if it remains less than 60, we're going to go ahead and give epinephrine and volume. So let's review real quickly. When we're doing a delivery, what shoulder do we deliver first in a usual head first delivery? And the answer to that is the anterior. You're going to gently guide the patient down once the head delivers and deliver that anterior shoulder, and then bring the baby back up and deliver the posterior shoulder. What do we suspect in a young woman with a history of a tubal ligation who has a blood pressure of 60 over palp and a pulse of 130 with sudden left lower quadrant abdominal pain? This is an ectopic pregnancy, okay? We have to be suspicious of that. Even if she's had a tubal ligation, she is prone to a tubal pregnancy. And obviously we've got signs of shock here and bleeding, which means she's probably got a ruptured tube. And we have to treat that patient aggressively with fluids and transport emergently. What differentiates eclampsia from preeclampsia? The answer here is seizures and or coma. And remember, we treat eclamptic seizures differently. We use magnesium as a first-line treatment as opposed to any of our benzodiazepines. What's the safest position to transport a pregnant woman in her second or third trimester? And the answer there is left lateral recumbent. I want to make sure the patient's on their left side. It displaces the uterus off of the inferior vena cava, allowing the mom to get blood returned to her heart and maintain adequate cardiac output to supply oxygen and nutrients to the fetus. All right, that's all I got for you today. If you have any questions, please feel free to contact me. Um, Thank you very much for listening.